So we don't yet have real data to say whether there's an advantage to one or the other. I think the point we tried to make in the Crossfire session actually ended up being that patient selection is paramount. So there are probably patients who present with very aggressive, high volume, rapidly growing disease in whom it absolutely makes sense to do triplet therapy with docetaxel added. However, we are also getting newer triplets that are more molecularly selected, things like PARP inhibitors for patients with BRCA2 alterations. So there are going to be patients in whom triplets appropriate, but your typical prostate cancer patient presenting with metastatic disease can have many, many years of good cancer control on an ADT and ARPI doublet, and in fact can have quite good quality of life. There are certainly side effects to AR pathway inhibitors, but they have the advantage of not having long-lasting potential toxicity such as peripheral neuropathy that you can see with docetaxel chemotherapy. And there's also not that short-term risk of febrile neutropenia or some really more significant toxicities that chemotherapy can have. So it has those advantages, and we know that patients on average can have years of cancer control before we have to start adding additional treatments once the cancer shows resistance.